All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. This is the favorite part, that is a chit chat. And hello everyone, including Margaret. And I have a number of folks here. Dee is here, Jana is here, Susan, Shri, Michelle, Rajesh, Margaret, Dr. Z, Sigrid, Kelly, Texas, Doug, Ken, Jana, Venus, Trevor, and more people now. Algebra, Margaret, D88, Gold Country, Big Ten fans, Ken, and the list continues. So I'm happy about the discussion that we did today. It is a preprint. I am sure that the anti-Ivermectin squad will now get out once again and start hammering this study as well. I'm also confident at the data and the methods. There are some adjustments to the studies that they had done on the way because of the change in Israel's policy to let people go back after 10 days of if they were asymptomatic. So it is possible that you would see some folks making comments in that area. Important thing is to look at the result. Results are statistically significant. They are done by a professor and his team that have done a rigorous work as well. I would definitely wish that there are bigger studies, but this is a good, robust, strong study. So Doug says, what comorbidities were included and excluded? Let's talk about them. Doug, good question. Roman, welcome back. And Jim, if he's here, I'm sorry I saw your comment in the last talk that you were having some tachycardias and you need to go back to the hospital. Good luck to you, prayers with you, and I hope that you recover completely and soon. Pass in Time says, I missed something important about ivermectin. Yes, Pass in Time, you missed the study from Israel, which is on the screen right now by Dr. Eli Schwartz and his team. So let's look at Doug's question. Doug said, what comorbidities did they include and exclude? Which is a good question. That is, if we make it practical to say, if I have some comorbidities, should I take it or not? Remember, their reason to exclude was not that ivermectin would cause an issue. The reason to exclude was the comorbidity may be such that the person might become severe and end up in a hospital where they cannot follow in the hospital and continue with the treatment, because the person who ends up in a hospital is in different hands, different administration. So they did not include anyone who may have that chance, not that any comorbidity was a contraindication. So let's look at it. I think I had read the list here in their exclusion criteria. Study design, population. So here, patients were excluded if they weighed below 60, were with known allergy to the drug, unable to take oral. So we talked about that. Then patients with comorbidities of cardiovascular diseases, diabetes, chronic respiratory disease, excluding mild intermittent asthma, hypertension, and or cancer, were defined as high-risk patients. These are the general top comorbidities. And once again, the point was not this, that they cannot take the medicine. For example, here, cardiovascular disease patient, can they take the medicine? Yes. Diabetics, can they take the medicine? Yes. Chronic respiratory disease patients? Yes. Hypertension patients? Yes. Cancer patients? Yes. So it's not about they cannot take the medicine. It is that because they're the top 10, one of the top 10 comorbidities, or they're in the list of top 10 comorbidities, and they could not continue to follow up with them. Does that answer your question, Doug? Roman, I saw your comment in the last video that you had gone to Wisconsin and had some fun, so very good. So welcome back. I love Wisconsin. Although I lived there for a year, I used to be in Menominee Falls in Wisconsin. Very cold, but beautiful area. So Granny says, possible myocarditis issues are connected to two vaccinations. So I was actually going to talk about the myocarditis today. And then I saw this study. So I have a list of topics that I should talk about. This was there in as well, and I thought this was more important. So that is very important as well. But for today's, this was the priority. So hopefully tomorrow. The second thing is, I think that this Friday and Saturday is what I wanted to do the marathon. The question is, some of the cool beans have said that, hey, inform the public more broadly before you do it. So it is a short notice today and tomorrow. Should we wait for the next weekend? Should we do Monday to? I'm trying to do it on a weekend, but within the weekend, maybe one day, for example, Friday, and then one weekend day, so I can have a weekend day as well. Plus, you can have some weekday with me as well. So what do you think? Should we do this Friday and Saturday, or should we move it to the next week to be able to publicize more? If that is the case, I think either we do next Saturday, Friday, Saturday, or we do this Friday, Saturday, or we do this Wednesday, coming week's Wednesday, and then it just continues. I think that gives us enough time to kind of inform the public as well. Okay, so now let's see the questions. So PJ says, Wisconsin loves Loofy. Where can we find your long hauler protocol? So long hauler protocol will be on FLCCC. They are in the process of writing it, designing it the way their protocols look and feel. So I think they have a designer and a composer. So they are doing that, and in another few days it should be out. Roman says, Dr. Been Medical Lectures, cool beans, glad to be back, and thank you. Have so much to catch up on with prior videos. Welcome back. So Denise says, colder up in Appleton, Wisconsin. So Doug says, yes, but hypertension. So why did they exclude hypertension? Hypertension is one of the comorbidities that can cause severity, but that in itself, we have done this discussion in the past, hypertension itself is not a pathology that can cause exacerbation of COVID, but a person of hypertension sometimes may have cardiac issues like cardiac failure or hypertrophies, which then when a load of SARS-CoV-2 type arrives on their body, their cardiovascular system may not be able to take care of themselves very well. So it's not the hypertension, it is the state of heart. So JStack says, is neutropenia and leukopenia a result of long COVID? I know that the ratio gets disturbed and neutropenia occurs in active COVID. It is possible that that is happening in the long COVID as well. What I do not know is the long COVID causing leukopenia. So ideally, leukopenia should not happen. So you should see other reasons for leukopenia as well. It may be long COVID. Alexander says, hello, Dr. Been, can you analyze this meta-analysis of Ivermectin from the Ministry of Chile? Sure, we can. There are so many meta-analyses now. For example, Dr. Paul Marek today sent a document to a bunch of people. I was included on that for Cochrane analysis, which they're also doing meta-analysis. So I guess there are lots of people. Dr. Teslari's team had done meta-analysis. Now Cochrane is doing meta-analysis here in Chile. So we can, I think that even more than the meta-analysis, we should look at the studies to see why are some studies rejected or deemed not good. Just to have our own, instead of saying this person said so and that person said so, we can actually look at them. Okay, let's see. Louis says, what is the study Dr. Corey was referred to the other day? He stated it may be the up or down for global acceptance. Tinfoil hat wonders that pharma and government will try and kill it. Rule 4M. I do not know what was he talking about, so I'll have to ask him. and generally big pharma is already trying to kill it. They are actually not trying, they've already succeeded. We are trying to get back. Fluffy Luffy. So something is here, and this is not Luffy, this is Kyrie. Kyrie is just, hey Kyrie, what are you doing? Kyrie? So Kyrie is a quiet one. She does not respond. But now she just turned back and she's going. She didn't like me talking with her. Uh, Bambi says, I thank you. You should wait, especially given your neck problems. Agreed. But I think it's going to take some time for the neck problems to recover. That I have. So, if I could train my camera to show you my setup, my chair height is lesser than my table height. So my arms are usually at this angle. And then my drawing pad is like this. So all of this is ergonomically incorrect and I have to fix this. Fortunately, it is a standing desk, so I can stand as well. But I think the thing that has happened is not going to go away very soon. I think there is a part of the nerve that has become damaged because there is a triangular part here in my hand and back of the palm that is now numb. I cannot feel in this area. So I think that is a permanent damage. So thank you very much, William, for your super chat. Question: when you get a chance, could you ask Dr. Corey if he has a database of what hospitals in the US use the FLCC protocol? We have doctors for outpatient treatment, but what hospital could we go to if needed? I think that there is no hospital, I would ask him, but I think there is no hospital that officially uses the protocol or ivermectin. It is really the irritation is the ivermectin in there. Art Patron Forever says, see worldometer for Peru. Peru is in a bad situation. Okay, let's do it. Yeah, we had not seen the so as usual, starting with Israel. Israel is look out. So since when did they report last? April 28. So from April 28, since April 28, then May and June, so almost more than 34, 5 days, they have not reported any further cases. Active cases are down to 356. They were down to that number really in the beginning, March 17. So very good. And the number of deaths are still continuing. That is a result of people who were sick about a couple of weeks and more ago. So 4 deaths here. Now, if we go to Peru, what is the right pronunciation for Peru? I'm used to calling it Peru in my language. So here, wow, this is not good. They have a decline in cases, but there still are a lot of cases. Lots of deaths as well. Yeah, Peru is not doing good. So the Cool Bean who asked me, so total cases are almost 2 million. So the Cool Bean who asked me about so they were asking about Chile, not Peru. So yeah, Peru is not doing good. How is, I haven't seen US for some days. US. Total cases in US, 34 million. I cannot imagine. Although I know that this is happening, I cannot imagine. Good news, look at the daily cases down to 9,000. I saw 12,000 per day, 9,000 per day. This is compared to 304,000 per day. And active cases are coming down, but still 5.5 million. And unfortunately, the deaths are continuing as well. But compared to, let's say, at the peak, 4,400 deaths in one day, compare that to 300 deaths. So really reduced. How is India? 28 million. So total cases are very high. What is their total case at this time? 28 million. Look at the wave. They have actually pretty much moved it downwards. So it is not going down to zero yet, but this is a very fast decline, coming down from 414,000 per day to now 126, 133. But consider their population. And then in such a big population, bringing it down so fast and so much is actually very, very interesting. And I believe this is the, again, social distancing, masks, everything, plus ivermectin. 1.8 million. And of course, unfortunately, the deaths would not fall that rapidly because it would take 2 to 6 weeks for the patients who are already in hospital for them to start reducing, and then the number of deaths would reduce. So how is UK? I haven't looked at these countries for some days since I've not been doing the morning talks. UK. So UK total cases still high, 4.4 million. UK has a very tiny increase as well. It is not significant yet to become a wave. To me, it looks like there will be some increase, but that would stay percolating at this lower level. So they were at one time 67,000 cases per day, and now they are 3,000 cases per day. So very reduced. Active cases 71,000. They had 71,000-ish cases on September 14. So this is a pre-variant time. So those folks who are saying that the 617.2 is really causing disaster. No, if you want to see disaster, that is the Kent variant. What was that? B117? That started in September. This is the result of that. And look at the exponential growth that you saw. You are not seeing that here. And number of deaths, this is so admirable. So are they not reporting deaths, or they do not have deaths? So 7-day moving average is 7. So that is 15 deaths on May 25. May 25. Today is June 2nd. And then that's it. Very, very, very nice for UK. A Simple Garden says, I think many of us had gut issues first, and it was one of the symptoms of underlying immune issues that made us susceptible to being long haulers. It is possible. So that gut issues that you're alluding to is also folks saying that was MCAS, or mast cell activation. So some people had mast cell issues, but they were not aware. It had not become symptomatic enough, or if there were symptoms, they did not connect that this is MCAS. And so the COVID revealed MCAS. So that is possible. In the long haul protocol that I have written, what I have seen is the following. Majority responded to steroids. A second majority, and you can start in any order, responds very well to ivermectin, to the point, and I've tweeted this many times, to the point that they refuse to take steroids afterwards. They say, we're done, we're happy. So if it is steroid, that is a suppression of the immune system, which includes mast cell as well. And so that is a very broad category, just the whole immune system down. But recovering after steroid therapy tells me that the immune system, when it was quiet down, it got a chance to reset itself and become stabilized again. And now the person has recovered without the need of the medication. This is not MCAS. MCAS continues to percolate and continues to bother. Folks who respond very well to ivermectin may have viral debris, for example, pieces of spike protein or some other RNA pieces or something sitting inside the cell, duplicating with the cells. And then ivermectin going in and kind of helping with that, plus some help with the inflammation. Ivermectin is not a potent anti-inflammatory. if that was the case, we'll be using it as an anti-inflammatory all the time at homes, like instead of Tylenols or Brufens or those things. But it has a combinatorial effect. So that is what I've seen mainly. Then I have seen antihistamines or MCAS related medicines. So I think multiple pathologies are involved. Murha says, any word about having Dr. Shetty on? I have not yet asked him. So we reached out to Dr. DeMello, and now I want to have Dr. Eli Schwartz. And I have a couple of more doctors in my mind as well. There is a researcher who did research on, I forgot, coagulation related research, and I requested them to come and talk. So I would see if we can get Dr. Shetty on as well. We are also trying to get Dr. A.K. Chaurasia on as well. Maximus says, what about Pfizer biodistribution study that shows spike protein accumulating in tissues, glands, and organs? So I have to still work on that one to figure out. So yesterday we talked about the possibility of the spike proteins spilling out in the tissue, in the blood, and then causing issues. Although I'm not yet impressed with that hypothesis, but that is a hypothesis. It may be proved. Now for this one, this was my thought was to talk about cardiac inflammation and to talk about the spike proteins accumulating in tissues. So we became distracted with the spike protein spilling thing yesterday. Today, I wanted to discuss this Professor Eli Schwartz discussion. Now, either tomorrow we'll talk about Maximus's question or heart's inflammation. But these are the things that I have in my list. So Terry says, will Pfizer protect us against the Viet Nam variant? Yes, so correct that the Viet Nam variant has a combination of two variants, but still these are, if it combines, for example, the UK 117 had, I think, about 21 mutations, and out of those there were 3 that were significant, if I'm recalling correctly. I may not be. And the 6172 or 617 also has 2 mutations that are important. It has 13 if I recall correctly. So even if you take the most dangerous mutations, 2 from 617 and 3 from 117, and combine them, some of those are actually duplicate. That is why they're saying it has both. So let's say there is one that is duplicate. Let's say 485 is duplicate. Then we have 4 mutations. Is that sufficient to bring down the vaccine? I don't think so. Is that sufficient to bring down an already infected person and they have immunity? I don't think so. Is that sufficient to bring down a monoclonal antibody? Yes, because monoclonal antibody is only connecting at one place. It is one binder. It only knows to bind at one place. And if that place got changed, then that monoclonal antibody is out. Similarly, convalescent plasma, if the convalescent plasma doesn't have the right kind of antibodies, then that can become less efficacious too. So my thinking is that the plasma plus original infection developed immunity, vaccine plus original infection, they both would continue. Kevin Brazda says, what stage of the pandemic are we in now? Are cases going to keep dropping? I think so. So let me actually look at the whole world together. And again, the answer also depends upon who do you ask, and if that person or persons are going to be saying that, hey, doom days are here, versus those who are like me, who says, let's just keep looking at things more objectively and see where we are going. So look, this is the world, and we are going down. Daily cases, this is worldwide, correct? Active cases, closed cases, this is world. 172 million cases, 3.7 million deaths. So 366 or 447 total cases. This is a number that alone, US alone was having this kind of a number on daily basis, or India a few weeks ago had that. So if it is a combined number for the whole world, then of course we are in a much better place. And I think we would continue to go down. I know that there are people who are waiting for SARS-CoV-3 who are saying that the vaccines are going to develop variants, which is incorrect. Vaccines did not develop variants, or a more general statement will be variants can be developed in any person, vaccinated or not. And so there are folks who are hoping that there will be some SARS-CoV-2 3. And the reason I'm saying that there are folks, because I get comments and where people say that you just wait, we are waiting and we'll show you. So I actually don't wait for a negative thing. We are looking at the results. They are becoming better. We are moving towards betterment. The hard part last year and the early part of this year is over. Now we have to just, individual communities are still struggling, some more, some less, but generally we are coming out of it. So Dennis says, please look specifically at Japan biodistribution. So I have a cool bean friend who has actually sent me the Japan's translation. Actually, he is right now texted me as well. So here he has sent me, here's a translated copy of the Japanese study. So I have the translated copy thanks to him. His name is Ray. I would reserve the last name, and I would look into that. So Dennis, thank you. I have that in my mind. Pratik says, Dr. Been, your thoughts on the Ivermectin trial from Colombia. Dr. Faheem Younus recently tweeted saying the results of Ivermectin aren't promising. So Dr. Faheem has been so on both sides. There are people who are who speak with authority and aggression, and they both sides have good things they can use and bad things they can use. Do you know what keeps me sane in this? And that probably is not a possibility for everyone here. That is my practice. When I practice and I use Ivermectin for my patients and I see them recovering and I see them getting out of long haul and I see them getting out of anosmias and recovering fast, and folks who I was afraid that this person is going to end up on a ventilator, and then they recover. So because of that, I stay sane and confident that yes, this is working. And how do I see it? Of course, my work here is not presented as a study. I'm not doing it as a study. There is no placebo-controlled, randomized, double-blind study going on. But the way I look at that is the following. If out of 100 patients, 20% have to end up in a hospital. That's the normal stat, right? 100 patients, not 100 people. Out of 100 COVID patients, 19 to 20% would end up in a hospital. And this changes according to various communities and their controls and their population type and comorbidities and socioeconomic status, but 19% generally. Out of those 19, so out of this 100, 19 went to hospital. Then out of this 100, the 19 that went to hospital, 5 will end up in ICU, and then 3 can die. So 3% can die of the patients, 5% will be in ICU, 19% will be in the hospital. I have now managed hundreds of patients, and the only one case where the patient, she was obese, her son is my class fellow, I have discussed it. He contacted me when she developed COVID, and she was an outpatient patient, and she had both vaccine doses as well. And I started her on Ivermectin plus, I believe, famotidine and cyproheptadine. I think they couldn't get all of them, but I'm sure they got Ivermectin. Other things, for example, prone breathing, and those were not possible. She was obese, and she passed away. So from outpatient, she became, when he talked with me, her oxygenation was going down very fast. Normally, when I give ivermectin, the oxygen levels actually bounce back, but for her, no, they stabilized, then deteriorated again. They ended up in a hospital, and then we know that she passed away. That is one case for me out of hundreds of patients. So what keeps me anchored is that if it is a normal standard patient management, then I should expect 20% to end up in a hospital. So let's say I'm doing very good. I am helping and I'm aggressive. So maybe then not 20%, 10%, maybe 5%. But I have out of hundreds and hundreds and hundreds of patients, just one patient. That is what keeps me confident that what I'm doing and what is the result of ivermectin is positive. Now the studies come back and Dr. Faheem like folks come back and they say, hey, this is bad. I would suggest to them is try it. It's not harmful. Try it. See if it helps. If it helps, do more. If it doesn't help, come back and tell us that it didn't help. Instead of picking up this study and that study, man, do your practice. I always think about this one. So sorry, you have now invoked a Dr. Been rant. I always think about this thing. In the beginning, when medicine started, there were no RCTs. So we started using medicines. For example, very often we talk about neem, or we talk about jushanda, or we talk about black seed oil, and so on. Curcumin. And there are many more. I just know these handful. There are studies, yes, but these have been used when people told others that, hey, I brought this plant and this plant does this and you should use it too. Medicine's foundation is based on these people's ancient elders of ours who said which plant does what. And then slowly we started figuring out what molecule, then we started testing them, then we started doing studies on them. So basic medicine is that once you found something that can be helpful, you use that. Instead of just coming out with guns saying, I'm gonna shoot down anyone who does not have an RCT behind them. These folks cannot practice, they cannot think. For them, the thinking is RCT. If Dr. Eli Schwartz has done the thinking and brought it in a platter to Dr. Faheem, then he'll be happy that, hey, I got it, now I can work on it. Otherwise, he will not be. I think it is not harmful to administer ivermectin. It is safer. So if somebody says that, hey, you know what, Mubin is saying here, that Dr. Faheem, I'm talking about a doctor, that a doctor should give ivermectin, and Mubin is talking about a dangerous drug, then that is bad. But here we're talking about ivermectin. So anyways, rant stopped. I have been seeing his tweets and I kind of always get amused. Arun says 20% end up in a hospital means. So look, what happens is this. In a community, let's go down here. Let's say this is a community. In this community, there are 100 people. Out of these 100, how many will get infected, we do not know. And only when the pandemic would stop, we will know. For example, let's take US as a community. So far in the US, out of 330 million, I hope I'm putting those zeros correctly. Out of 330 million people, so far, let's say 38 million have become infected. What is this percentage? If this was 33 million, then that would be about 10%. So exactly how many out of 100 is not yet known because pandemic is not over. So we cannot say that. But if you take 100 patients, so out of whatever community they were, they have become sick. They have gotten COVID. Out of 100 COVID, these 100 COVID came from 1,000 or 2,000 or a million, I do not know. But out of 100 COVID, 20 of them, usually 19 to 20%, and these numbers vary. For example, in Italy, this was a higher number because their population was more advanced in age. In other countries, in some countries, it is a lower number because their population is younger in age. So this number can change, but worldwide number is out of 100 patients, 19 to 20% would develop enough oxygen drop that they would have to be in a hospital with for the help with oxygen. Then in these 19, so out of 119, right? In these 19, there will be 5 that will 1, 2, 3, 4, 5 that will be in the ICU. And then out of these 5 that went to ICU, there is a chance that 3 of them will die. And please remember, this is them, this is us, right? It is people from us. So 3 of them will die. So then out of 100 patients, not 100 people who do not have COVID, out of 100 who have COVID, 3% will die, 5% will be in ICU, 19% will be in hospital, and then 81% will recover without much intervention. So as a doctor, when I see, let's say if I treat 100 patients and none of them end up in a hospital or in ICU, then I can look at it in this way, that maybe I was fortunate to manage healthier patients who were all outpatient type age and they didn't have comorbidities. But generally, when somebody calls me to manage their patient, they are usually in a bad shape. They are usually in a stressed state. So I get less younger, healthier patients, and I get more advanced age patients with comorbidities where because my students mostly are doctors, they know that, okay, we need to go to Mubin to do this. So my patients are usually at-risk patients. But even if that is the case, the question is, out of 100, how many went to hospital? None of my patients, other than this one patient, none of my patients have gone to hospital till today. 0. Again, one patient. And so let's say if I manage first 100 and nobody ended up in a hospital, then we can say, you know what, that is just a fluke. Just happened. Maybe he got good socioeconomic status or something. Although socioeconomic status doesn't have much to do with this. I'm just trying to give some examples. So they said, okay, fine, have Mubin manage another 100. That is fine as well. Another 100. So many, many hundreds I have managed, and just one patient who has passed away, unfortunately. So this is an example of something working. Now, if that thing is just because Mubin is managing, then that is not correct. It is, what am I doing? And what I'm doing is ivermectin, steroids, hydroxys, vitamin D, zinc, quercetin, other supplements. If needed steroid, then steroids. If inhaler are needed, then inhalers. If I have to control their diabetes, I stress to their family members that I need diabetes fully controlled, or I'm not talking with you. So diabetes is controlled, hygiene is controlled, isolation is done, nutritional status is controlled. I call every 2 hours. They know what things to provide to me. And for me, do you know the best? How do I know the patient has recovered? When the patient's family increases the gap between sending me the updates. So they all know that they have to provide me temperature, heart rate, blood pressure, respiratory rate, and oxygen saturation. They have to send it to me every 2-3 hours. It is quite, I am a burden for the patient as a doctor, that I just keep asking them. So their daughter, son, whoever is the doctor who reached out to me, they have to do this all the time. So then I see that their reporting interval increases. which tells me that they're improving. And then a time comes that they disappear. And then after a couple of days, they say, sir, thank you, they're fine. That is, I know when this is happening, and I say, all right, so they are on the right track. So you are very welcome, Ace. So I don't know how did I went. So that was Arun's question. So I hope that question was. Ruby Zaret says, first wave killed the old, second and third wave killed the young. I hope that we... So Timothy says, is there any information about Novavax? Not yet, meaning the information is that they're still in phase 3, still preparing the results and they're still conducting it. And it looks like somewhere in August, September timeframe. Would at that time US say that yes, we need your vaccine is a different question. So Jana, this is actually very, very accurate. So here is a new thing that I think we should all, this is happening, people are saying it, but this is not being recognized. Just like Ivermectin is not being recognized, long haulers are not being recognized. There is another group of people who are becoming sick after the vaccine, and they are not being recognized. They are gradually healing, some are not healing, and they are not being recognized as well. So you are correct, Jana, that is a, I was tweeting with someone and they were in that state as well. And so again, how do I see it? I feel that vaccine is important to take, but I think where we are dropping the ball, just like with COVID, we have dropped the ball. What we have done is we have dropped the ball to create protocols to say a person with the propensity for clotting should be managed this way during the vaccination. A person who may develop, let's say, tinnitus or others, we should manage them this way. We should stop it fast. A person who may have a vaccine-generated spike protein, let's say, we should have a response instead of fighting and just, kicking each other. We should have a response created to say, okay, this could happen. If this could happen, clotting, for example, it is simple to manage it if we have this protocol. You got the vaccine today, we would take with your vaccine, we'll take your blood as well, and we would do the test. Now, 5 days later, please tell us if you have those headaches or not. If so, come in, we'll do another test, we'll compare your previous labs with this lab, we'll know what is happening, and we'll keep going. That is a protocol to save people from these miseries. And it's just missing. It's just missing. William says, you previously said you use steroids usually beginning day 5 to 6 to avoid the day 8 crash. Just curious what steroid and dose and how many days do you typically RX? So depends upon age and their risk. For example, I have used dexamethasone injections. Most of the time I luck out because the patients who reach out to me, they have their doctor's son or daughter who reached out, and I can tell them that, hey, give them dexamethasone, and I know that a doctor will acquire it and inject it, and I can safely say it instead of saying go to a hospital. So in some cases I have to give dexamethasone, and I've done that. I would have preferred methylprednisolone. For example, this my class fellow's mother, I kept saying we need methylprednisolone, and he said we can't find it. So they had to give her dexa. If methyl, then methyl. If not that, and if I feel that they do not need injectable medicine, then I usually use prednisolone. And I can, depending upon the person, my minimum is 15 milligram per day, but I can go higher, much higher, with oral steroid as well, inhalers as well. Why I'm not saying the doses here, I don't want people to start taking over the counter. There are countries with the over the counter steroids and other drugs. ET says, question, could the efficacy of one dose of messenger RNA just keep going up by itself without the second shot? Any data on that? Not yet, but UK is continuing to experiment with various gaps. I'm sure that UK would have some data, and I'll have to look into that. I don't think US has that data. France, that is a very good idea. Open vaccine, so that the platform is open, people have less doubts about it and less suspicions. In addition to that, so Kyrie is here. Hey Kyrie, where is Luffy? So in addition to that, I think we should have an open WHO as well. This WHO is done. It is useless. It is negative. It is harmful. So we should now move towards a people-created WHO, not countries-created WHO, a people-created WHO that can then work for the people. Superknight says, I heard that people infected by a different virus have less chances of being infected by COVID. Is that true? I have not read it. So without reading, speaking here would be out of turn and kind of incorrect. I can speculate with you that it is possible that some viruses, which are, for example, RNA viruses or viruses, human coronaviruses, or other viruses that may have spike protein structures or the lipid structures similar to this one, they may create cross reactivity that can help against this one. But I haven't read that exactly which viruses. WT says, I just want to stick something into my arm right now. Careful. There are many things around that can be stuck in the arm, but you shouldn't do that. So Samina had talked about, said that, hey, can you invite Dr. Alam? So Samina, I do not know if Samina is here. If Samina is here, can you connect me with Dr. Alam so we can request her to join, request him to join? Okay, so looks like we don't have much questions. So L. Florencia says, Dr. Been, here in Manipur, India, people after vaccine gets infected with COVID and spread to entire family. It's false positive report and talking about the spread to the family who hasn't went out anywhere. How is it possible? It has happened in 5 to 10 households. It's a rumor, or is it really possible? Please clear my doubt. So Luffy and Kyrie are fighting. Okay, so Florencia, I have to read up to understand. There are so many rumors, and there may be some facts as well. Luffy, what happened? Did Kyrie beat you up? so Luffy gets slapped around by Kyrie. Okay, so how is it possible it has happened in 5? Florencia, I have to do some more research to know why this happened. The comment here, people after vaccine get infected, that can happen, but are you talking about shedding? People can shed, vaccinated and non-vaccinated. So Edmund says, if it's still possible to get infected after vaccine, why did CDC say no mask? Because CDC also do not have any credibility. So I say things that can get the channel shut down, which is fine. But you tell me, has CDC any credibility left? On the mask, a simple thing like mask, they have taken so many about turns. A simple thing about aerosol, they have changed so many times. I always submit this to Cool Beans, that if they are so indecisive, so incorrect on such simple things, then how do they have the credibility or even the competence to talk about things like ivermectin? Ivermectin is way above their pay grade. They have no idea how to talk about ivermectin. They cannot talk about aerosol or mask. So we need an organization that can actually talk about mask and aerosols with more competence, to give us that confidence that we are competent, so that they can talk about things like ivermectin. I think CDC should be barred because of their lower competence to talk about drugs. Roman says CDC is equal to Center for Disease Creation. There are so many. How would a new WHO CDC be immune from corruption? Yeah, that is a problem. So I think just like, for example, in the US, the founding fathers had created a structure that still supports it even when there is corruption, but that corruption has to be in a very limited structure. And compare that, those folks who would come back and say, you know what, US has a lot of corruption. Compare it to the countries that have a lot more corruption, and you'll see that the mechanisms here are still supportive of less corruption. Similarly, I believe that once this new organization is put together, we'll have to create rules and regulations that would try to keep it as immune as possible. Would that still become corrupted? Yes. Here is Loofy going after getting slapped by Kyrie. I always get amused. So Loofy goes and always bothers her. And when he bothers her, Kyrie is a quiet one. She was here a few minutes ago and she didn't say anything. And then Loofy goes and bothers her. Then she beats him up. Then Loofy becomes all whiny. Let me open the door for him. Loofy, you want to go there? So then he has to quietly go to the other room. Grace says, ask Loofy which immunity is stronger, vaccine or recovery from the disease. Loofy told me to say recovery from the disease is better, but getting the disease is very, very risky. So this idea that somehow vaccine is stronger than the original infection is not correct. William says, since subcutaneous tissue is less vascular and intramuscular injection hits the bloodstream quicker, would it be better to give these mRNA shots subcutaneous? Sure. Sure, that's fine. Morehouse says, so much information, misinformation in the comments. Okay, so let's do this. Let's now prepare for tomorrow. Wow, that is interesting. So Gold Country says, Dr. Been just now appeared on my screen with audio. I thought we were waiting for him to return. Strange. So we are almost 52 minutes, 53 minutes into it. So, Cool Beans, please remember for tomorrow morning, 9 o'clock, we'll talk with Dr. Daryl DeMello from India. He has done some significant work, and it is actually going to be our honor to have him. We'll ask him your questions as well. So I'll see him tomorrow. Please like, subscribe, and share. And then in addition, if you would like to support this work, there are 3 links in the description. One, if you don't like PayPal, you can buy me a coffee. You can also be a patron, and you can use PayPal as well to support. Thank you very much, and I'll see you tomorrow morning.